Good morning, everyone, and welcome to today's webinar sponsored by all the different organizations that you've seen on the slides, and a collaboration between the Cancer Council WA, BreastScreen WA, Sexual Health Quarters, and Women's and Newborn Health Service. We've got a really interesting morning of educational talks for you, focusing on skin cancer, skin care, and also palliative care. The event will run with the speakers speaking in order. So Dr. Gary Maloney, dermatologist. We've got Sally Blaine from the Cancer Council WA, and Dr. Derek Eng, who's a palliative care physician. Then we'll try to keep questions. The question panel will be at about 10:30. So please post questions as you go in the question and answer function, and these will be done as a panel response a little bit later on. So I'm just going to introduce Dr. Gary Maloney, the first speaker. So Gary is a consultant dermatologist in Perth and undertakes research outreach clinics to Exmouth and Carnarvon. His interests lie in skin cancer management and in the general dermatological problems of acne, psoriasis, dermatitis, and hyperhidrosis. He sits on the executive of the WA faculty of the Australasian College of Dermatologists, and away from work, if he's not chasing his two daughters, you'll find him playing golf or trying to fix his lawn. So with no further ado, I would like to hand over now to Gary to take the education on. Thank you.
Thank you, Eric. So I'm talking on dermoscopy and skin checks today, and I'd like to say thank you to the organisers for the opportunity. So today I'm talking to these learning objectives, and by the end of the session, I'm going to hopefully highlight and identify situations where a skin check is necessary, how to perform a skin check appropriately, and to understand the key clinical and dermoscopic features of the more common pigmented and non-pigmented skin lesions. So first of all, identifying when a skin check is necessary. As you know, in Australia, we have a high rate of skin cancers, and public awareness is quite high as a result, including from programs such as SunSmart, Slip, Slop, Slap, etc. Most Australians are aware that early detection and early treatment reduces the harm from skin cancers, but we don't have a population-based screening program for skin cancer or melanoma, particularly in Australia. This has been looked at, but we have too few melanomas, and reducing their number leads to too little reduction in mortality for the economics to work currently. For BCC and SCC, there's too little harm come from these tumours at this stage. So currently, patient self-examination with opportunistic screening is the current standard. So when to perform a skin check? There's really two situations. People will self-present for a skin check. They might have a history of skin cancer or be at high risk. These people are often city dwellers with high levels of education. Then there are opportunistic skin checks, so whereby the doctor, usually the GP, would recognise an individual patient as having a high risk profile, and they may display some sun damage such as visible on the hands or face. In assessing a patient, their Fitzpatrick skin phototype is an important first step. These are broken up into 6 categories. The first is skin phototype 1, which is the person with red hair and blue eyes. These people burn very easily and will never tan. Type 2 skin predominantly burns, but may tan, though with difficulty. Skin phototype 3 will mostly tan, actually. They may sunburn, but they tend to tan more easily. Skin phototype 4 rarely tans, rarely burns, usually tans quite easily, and this is typically Asian skin. 5 and 6 are the darker skin types, Indian skin 5 and African type skin phototype 6. So establishing a risk profile for your patient in front of you is very important. This is from an article by Rod Sinclair, which highlights who would categorise as high risk. These patients need 3 monthly self-examination and probably a 12-monthly skin check with their doctor. These are patients with red hair. They may have type 1 skin and more than 45 years old, type 2 skin and older again, over 65. They could have a family history of melanoma and themselves be older than 15. They may have more than 100 nevi or more than 10 atypical nevi, which is a marker of risk. A personal history of melanoma or a past history of non-melanoma skin cancer or more than 20 solar keratoses. Of medium risk are patients with blue eyes, type 1 skin between 25 and 45 years of age, so a little younger, type 2 skin that is older, 45 to 65, type 3 skin that's older than 65 years, a family history of non-melanoma skin cancers, or a personal history of solar keratosis, or many sunburns in their history. And these patients should be considered to have perhaps 6 monthly self-examination at home, and perhaps a formal skin check with their doctor every 2 to 5 years. Of the lowest risk are fairer skin types less than 25 years old, medium risk skin type with older than 45, and darker skin types older than 65. These are quite low risk, and usually a once-off skin check and explanation of the risk of UV damage and how to perform an annual self-check. The dorsal hands are a good marker for the risk of a skin cancer and the degree of sun damage that's visible. A neat study showed that actinic keratoses particularly had an association of BCCs 3 times higher than those without solar keratoses. The other signs of solar elastosis, solar lentigenes and telangiectasia had slightly lower associated risk, but still were significant for increased risk of a skin cancer, particularly BCC. So when you assess a patient, you ask your traditional history, so their history of skin cancers themselves or family history, UV exposure, their medical history generally, including any immunodeficiencies, if they've had burns or radiotherapy, any medications, particularly immunosuppressive medications or chemotherapy. There are some special populations that are automatically high risk, such as those with inherited syndromes like Gorlin syndrome or xeroderma pigmentosum, those who have an immune deficiency disorder, childhood cancer survivors who may have had chemotherapy at a young age, and those currently immunosuppressed. So the history of the lesion is important, any history of change or growth, whether it's bleeding, if it's changing in some other way. And then you move on to the examination. For the examination, you need good light, you need a magnification source, and you need the patient appropriately exposed to examine. The question then arises what to examine, and we're all time poor, particularly in general practice when opportunistic skin screening may not be easily done on the fly. And if possible, it's best to bring the patient back for a dedicated appointment. And what you examine will vary depending on how much time you have, your degree of suspicion for a skin cancer. Would you just do the presenting complaint or do you do a full skin check? There'll be clues in the history and also on your initial impression of the sun damage on their face and hands. So a full skin check means just that. You should examine essentially all of the skin, starting from the scalp and moving down. Also pay attention to the axillae, nails, palms and soles, the buttocks. The genitals is a little difficult to routinely examine. It's best to ask the patient if they have any lesions of concern there. I'm going to show now a video on how to perform a full skin check, and this is courtesy of Dr. Martin Haskett in Victoria.
There is no correct way to do this. However done, it must be simply systematic and repetitive to be effective and efficient, minimising the chance that lesions will be missed and taking no longer than 3 to 5 minutes. The most essential ingredient is good lighting, and ambient daylight provision from appropriately screened windows or skylights is desirable. Artificial light should be added. 4 daylight type fluorescent tubes on the ceiling immediately above the couch in a room of standard height will be adequate. A light source, worn as a headlamp, allows the greatest flexibility and efficiency for specific body sites such as the ear canals and digital web spaces. If possible, position the examination couch away from a corner or a wall to give easy access to all parts of the body and reduce the amount of movement required by the patient. A motorised couch removes the problem of steps getting in your way as you are moving around the couch. Have a trolley within arm's reach to accommodate your dermoscope, other tools, and a biopsy kit. Paint one wall of the consulting room grey and stand the patient in front of this to obtain better photographs. Discuss whether the patient wants a total examination or only assessment of the specific lesions that are of concern to them, and record their decision for medico-legal purposes. The patient must be adequately consented for a total skin examination to ensure they understand what is to happen, as many patients do not know that skin cancer does not just arise where the sun has struck them. Further explanation is required to achieve efficiency and effectiveness. It is important you control the examination. Explain that initially you will carry out a full and thorough check and will then return to address any specific lesion of concern to them. Lesions may be overlooked if a nervous or anxious patient distracts you from your systematic examination process by pointing out specific lesions. The patient must feel comfortable. Ensure that the room is warm, the examination couch is clean, and a gown or sheet is provided. Ensure that the patient has privacy for undressing and dressing. If required, call a chaperone in. For each area, initially stand away and scan the skin, making a general assessment of the level of solar damage and number of nevi, and also looking for the ugly duckling. Then focus in on any lesions which have attracted your attention using magnification or dermoscopy where appropriate. The system demonstrated here starts with the patient prone. The scalp is assessed first using the focal lighting device and parting of the hair to allow the skin below to be seen. The ears and retroauricular folds are also checked. Next, move to the posterior neck and back, the buttocks and legs. Pay attention to the toe web spaces and soles where melanoma is not uncommon. Assess both right and left sides of the body. The patient is turned over and the process repeated for the front of the body. When examining the face, turn the head from side to side and specifically assess the medial and lateral canthi of the eyes. Move the nose so that the nasolabial fold can be clearly seen. Check the lips and elevate the chin to examine both sides of the neck. Lift the arms away from the body and check the axillae. The genital areas are a very low incidence site of skin cancer and do not need routine assessment. Just ask the patient if they have any lesion in that region for which they would like your opinion. If appropriate, the lymph gland fields and liver can now be palpated. At this point, sit the patient up and reassess the important areas of the torso and the head and neck. The purpose of this is to see the skin with different light incidence and shadowing, which may reveal previously unseen lesions. Conclude by asking the patient to point out any specific lesions they remain worried by. Frequently, our eyes will move across lesions without the slightest concern, yet they may be the ones that the patient has been most anxious about. In addition, this question will lead you to lesions that you may have missed. It also reinforces that we're interested in patient self-examination, for this is still the most common way in which melanoma is detected. While the patient is dressing, you should create an appropriate record. Make notes recording basic information about risk factors such as sun damage that may have been discovered, and about any lesion that warrant dermoscopy or special consideration.
All right, moving on then to the third of our talking points, the key clinical and dermoscopic features of pigmented and non-pigmented lesions. So we've got brown spots and pink spots effectively, both malignant and benign to discuss. The importance of dermoscopy can't be understated. I probably don't have enough time today to go through all of the elements of dermoscopy, other than to say that it's important if you are examining the skin. Initially, using an algorithm is very important, such as these I've got here. I'm going to be talking about Menzies method, which is a 2-point method. You need to use your dermatoscope regularly and practice to gain good competence. There are some courses you can undertake, such as this through the Australasian College of Dermatologists, and plenty of online resources. I'm going to put this slide back up at the end so that you can make note of these key websites, which are very useful. Dermatoscopes come in various types, and some are a bit more sturdy than others, and some are non-contact and contact. The contact dermatoscope needs a liquid interface, and my preference is aqueum gel. It sterilizes between patients and has the right viscosity. So you start with a proven technique, learn it and use your dermatoscope, and eventually it becomes much more instinctive so that you glance at a lesion for 1 second and you know what's going on. So the two-step method is, first of all, to determine whether it's melanocytic, and if so, is it benign or malignant? So by melanocytic, I mean it's made of melanocytes rather than simply pigmented. And these are the clues to a melanocytic lesion. It may have a network, it may have radial streaks, a globular pattern, homogeneous blue pigment as seen in blue nevi, or on the acral skin, hands and feet, a parallel ridge pattern. Parallel furrow pattern. So the melanocytic network is made up of fine brown lines with central pale circles. And this represents a sort of 2D version of the convoluted Ricci ridges of the skin. This lesion is quite bland looking. It has a neat melanocytic network, nice thin lines. It's darker at the periphery and fades at the edge. And this is easily diagnosed as a benign junctional nevus. So no further investigation is required. If it's not melanocytic, then you need to determine whether you can make another specific diagnosis for a pigmented spot, such as a dermatofibroma, a seborrheic keratosis. Could it be a pigmented BCC, a solar lentigo, or hemangioma? If you can't make another diagnosis, then you should assume it's melanocytic. Once determining that it's melanocytic, you then need to determine, is there a clue to a melanoma? The strongest clues are a blue-grey veil or an atypical pigment network. There are other clues, and the presence of any of these should then lead to a biopsy, preferably excisional biopsy. So the blue-grey veil is this dermal pigment that leads to a subtle blue colour. Blue light is reflected, whereas incident red light is absorbed, giving its bluish appearance. It reflects an immune response to possibly a malignancy. The atypical pigment network is much thicker lines, effectively. They often have sharp cutoff with the surrounding skin rather than bleeding out nicely into the unaffected area. Some of the other features of malignancy to look for are radial streaming, whereby you get thick lines extending directly out into the surrounding skin. This lesion also has a blue-grey veil. Pseudopods at the edge of the lesion. These are small tennis racket-shaped areas of pigmentation which show progressive growth laterally. The presence of peripheral dots, black dots or brown dots at the edge of the lesion. Structureless areas or scar-like depigmented areas. And multiple colours are all clues to a malignancy and require a biopsy. Moving on to some examples, and I have to say straight up that the examples I'm showing are for illustrative purposes, and they are very obviously melanomas. The reason I've chosen them is because they show lots of features simultaneously. More commonly, the clues are more subtle, and that's where lots of practice is useful. And getting some feedback on what you've seen and what the ultimate histopathology, so that you sort of develop your dermoscopic technique and improve your skills, is crucial. This lesion shows an atypical network, multiple colours, bit blue and grey, brown, blacks. It has pseudopods at this edge and peripheral brown dots. Ultimately, this was diagnosed after excision as a superficial spreading melanoma, 0.6 millimetre Breslow thickness. This lesion also quite atypical, multiple colours, pseudopods, peripheral dots. Again, an invasive melanoma. Here we see pseudopods at the top here, multiple colours, this subtle blue-grey veil reflecting an immune reaction. A 0.4 millimetre example in this situation. This lesion shows an inverse network. A normal network shows brown lines and pale centres. This one has white lines and darker centres. And this is highly specific for melanoma. A 0.7 millimetre Breslow thick melanoma. The next lesion is the pigmented BCC. These are most often not pigmented, but the pigment is quite typical when present. Menzies describes two key features for the dermoscopic features of a pigmented BCC to look for. And that firstly is no melanocytic network, And then one of these other features, arborizing telangiectasia, surface ulceration, pigmented leaf-like structures or spoke wheels, which look very similar to each other, and blue-grey ovoid nests. Be careful of the mimics of BCC, such as sebaceous hyperplasia and intradermal nevi. So here, a pigmented BCC, you can see the typical arborizing telangiectasia, arborizing meaning tree-like, with a tree trunk followed by branches, twigs, etc. There's a blue-grey ovoid nest, and this milky pink stroma in the background is typical for a BCC. This example shows leaf-like structures looking a little like a maple leaf, sometimes called spoke wheel structures. Here, a pigmented BCC with a lot of pigment, many clods of this blue-grey dermal pigment. Other benign pigmented lesions to consider. The dermatofibroma is a firm button-like lesion. It dimples down when pinched, and that's a good clinical clue. They're quite benign. They don't need excision, but they can be pigmented. And this is the typical appearance, a scar-like structure centrally with a lacy, fine pigmented network around the edge. So both the dermoscopic and clinical features can be helpful, and you don't need to biopsy these. Solar lentigines are sun-related benign pigmentation, and will have either or both of a moth-eaten edge, looking a bit like a sort of coastal outline, or fingerprinting type pattern of swirling centrally, parallel swirling lines. Seborrheic keratosis is very common, very annoying age-related spots, perfectly benign and have no real risk of malignant transformation. When they're sort of stuck on keratoses like this, it's quite simple. When they're sort of macular and slightly odd, they often need a biopsy to exclude a melanoma. Dermoscopically, they show features of comedone-like openings, milial cysts, these pale areas, or sometimes a cerebriform surface. Again, showing those features here, milial cysts shine up quite brightly white. Sometimes at the edge, you can see these projections which are described as fat fingers, and this has, again, a more cerebriform surface. Dermoscopically, sometimes it's been likened to the appearance of Van Gogh's Starry Night. Moving then to the pink lesions, to the non-pigmented lesions. And nodular BCC is the most common form of skin cancer we see. They're usually skin-coloured. There is often a history of change, a shiny, pearly, translucent lesion with a rolled edge and sometimes central ulceration. I'll move through this fairly swiftly. Some pictures of nodular BCCs here. They have a very friable surface and will regularly ulcerate and are sometimes described by the patient as the sore that won't heal. Here, lots of central ulceration, but just a clue to a BCC at this pearly rim around the edge. The inner canthus is a common site, as is the nose. And dermoscopically, you can see these, again, sharply focused arborizing telangiectasia arising in a milky pink stroma. Another example here of a nodular BCC under the dermatoscope. The flatter they get, the more superficial they get, the more difficult it is actually to see the arborizing telangiectasia. And you've got to be careful not to press too hard with your dermatoscope because you can obliterate the vessels and lose that sign. Here again, a BCC, some subtle pigment visible under the dermatoscope, these blue-grey dots. This is typically a multifocal lesion. You can see small foci with central ulceration over each of these small nodules and more a superficial pattern in the center. There are some mimics of BCCs, including intradermal nevi. These have a different vessel pattern, so comma vessels is the typical feature here, and there's often some brown pigment, which we don't see in BCC. And so seeing this, you could safely leave this guy. On the face, often there is sebaceous hyperplasia, where you have this rosette of pale clods surrounding a central punctum. And the vessels here are often a corona, a surrounding sort of crown of thorns appearance. Moving then on to superficial BCCs, so well circumscribed thin plaques on the trunk and limbs, often have focal crusts and scaly. They initially look bright pink or purple, but after rubbing will turn an orange salmon color. So some examples here of multiple superficial BCCs. The edge will sometimes show a small raised pearly induration. This is a recurrent lesion after possibly some cryotherapy. Again, superficial BCC, very common, sun-exposed areas. The differential here includes Bowen's disease and sometimes rashes, inflammatory lesions like discoid eczema, psoriasis, a long-standing superficial BCC on the arm here. You know it's been there a long time because it's got a 1-cent coin in the picture. It's outlived the currency. Morphaic BCCs are a difficult problem. They look a little bit like a post-radiotherapy scar, pale sclerotic skin, subtle telangiectasia, and often have quite extensive subclinical progression beyond what's visible on the skin. Here, an ill-defined plaque in the sort of temporal preauricular area and on the upper lip. Here on the forehead, a subtle pale plaque. This would be quite an extensive lesion, and usually a 5 to 10 millimeter margin is required around these. Again, a morphic BCC on the nose. Perineural invasion is not uncommon. These have quite an infiltrative growth pattern within the skin. Moving then on to squamous lesions. So actinic keratosis, SCC in situ, also called Bowen's disease, and then invasive SCC. These are more closely associated with chronically sun-damaged skin, as opposed to BCC, which might be more associated with intermittent high-intensity sunburns, such as the office worker who gets burnt on the weekend. So actinic keratoses, very common. I'm sure most of you have seen these. They represent dysplasia rather than malignancy, and they in themselves are benign, though 1 in 1,000 per annum will turn into an invasive SCC. They're often flat and roughened, a bit sandpapery feeling, sometimes more hyperkeratotic, sometimes wart-like. This chap's got extensive sun damage with scattered confluent solar keratoses, and they're quite inflamed, as if he's been using some Efudix perhaps. He's got an invasive SCC developing up here. Again, hyperkeratotic solar keratoses. They're all smoke and no fire, these spots. You pick off the scale and there's no actual underlying tumour. Moving then to Bowen's disease, these are often asymptomatic scaly plaques. They have a propensity to lateral extension and only occasionally progress to invasive SCC. If they do, there's very high rates of metastasis, so we usually treat them. In the chronically sun-exposed areas, so head and neck, arms in men, and across the cheeks and lower legs in women. There's a differential to consider, including inflammatory conditions such as psoriasis. Examples then of Bowen's disease or SCC in situ. Red, scaly. Unlike BCCs, they tend to have a lot more hyperkeratosis on the surface. They feel much rougher, scaly. And then invasive SCC. So this may present as a nodule or an ulcer. There'll be a history of growth, sometimes rapid, and they tend to be quite tender. A small number can be locally aggressive, and the proportion that progress to metastasis to particularly lymph glands is around 1%. It depends a lot on the degree of differentiation. The more poorly differentiated, the higher the likelihood of metastasis. So a clinical diagnosis, there's a differential to consider, including keratoacanthoma or prurigo nodules, foreign bodies and cysts. Some examples here of tender nodules in chronically sun-exposed skin. The lip is a common site for SCC, and they are more aggressive here, higher rates of metastasis to lymph glands, and more common in smokers. And quite a horrible tumour here. Less exophytic here on the lip, they're more infiltrative. Ears, common site. The keratoacanthoma is a rapidly growing tumour that, by definition, spontaneously involutes, though it's quite difficult sometimes to know what is a well-differentiated SCC and what is a keratoacanthoma. So the best course of action here is to excise these rather than sit and wait and hope that they go. Again, a large keratoacanthoma. So finally, the take-home messages. We've discussed the situation in which a skin check is appropriate, and in reality, every patient should have their risk profile determined. in performing a full skin examination, make sure you allocate the correct amount of time, set up your room correctly and practice your system. And when it comes to dermoscopy and the features of skin cancers, every practice needs a dermatoscope. And I would suggest starting with a formal system before you hone your skills. Thanks to these people for their videos and photos. And I'll just leave that up for these online resources, very useful for learning some dermoscopy at home. Thanks so much for your time.
I'd like to now introduce the second speaker. Second speaker is Sally Blaine, and Sally has been the Cancer Council WA's SunSmart School Programs Coordinator for 6 years. Her role is about delivering skin cancer prevention messages and programs to all Western Australian school children in childhood services, including the Generation SunSmart online program, modules for educators and teachers. So there's a lot of information that Sally is going to impart this morning about how to best talk about skin care and how we can best talk to our patients about looking after their skin. I'll hand it over to Sally to take over. Thank you.
All right, thank you everybody for your time this morning. Before I start, I'd just like to acknowledge the traditional owners of the land that we're meeting on today, the Noongar Wadjuk people, and pay respects to elders past, present and emerging. I work in skin cancer prevention at in the SunSmart team at Cancer Council WA, and as mentioned, my work mainly focuses on reducing UV exposure of children and adolescents, not so much the clinical side of skin cancer. Today, I'll be describing our sun protection messages that we promote to the general population. Okay. So the content I'll be covering today includes the incidence of sun-related skin cancers in Australia, describing the link between UV exposure and skin cancer, the sun protection strategies that we promote and early detection, and balancing safe UV exposure with maintaining vitamin D levels. So, as mentioned by Gary, Australia has one of the highest rates of skin cancer in the world, with at least 2 out of 3 Australians developing some form of skin cancer before the age of 70. Our rates here are on par with New Zealand, but the rates in Australia and New Zealand are approximately double the incidence of the next ranked countries, which are those Scandinavian and Northern European countries, and about 2 to 3 times the rates in Canada, the US and the UK. The image there shows quite typical scene from the 70s. We hear a lot from particularly older people who spent their youth lying on Cottesloe Beach covered in coconut oil. They're the ones who are probably presenting themselves now to your GP practice. And we're seeing the effects of those behaviours now. Nearly all skin cancers are preventable by reducing exposure to UV radiation. So just a couple of key stats of skin cancer in Australia and Western Australia. So non-melanoma skin cancer is the most common form of cancer in Western Australia, but it's not reported to the cancer registry. Non-melanoma skin cancers account for 80% of all cancers diagnosed in Australia. And although non-melanoma skin cancers aren't as serious as melanoma, its high incidence does place a significant burden on our health system. The cost of treating those non-melanoma skin cancers in WA is about $70 million a year, and nationally it's close to about $1 billion per year. Across Australia, there are about 1 million GP patient consults per year for skin cancer. In 2017, 205 Western Australians died from skin cancer, and 2/3 of those were men. So it does have a higher mortality in men. Within Australia, Queenslanders have the highest rates of melanoma, followed by Western Australia and New South Wales. Melanoma incidence rates are higher in regional and remote areas than in major cities. Melanoma is also the most common cancer diagnosed in Australians aged 15 to 29 years, and that they account for more than 1/4 of all cancers in this age group. The good news is that there has been a substantial decline in recent years of melanoma incidence among young people under the age of 40 years, and it's actually halved in about the last 15 years. So despite skin cancer being preventable and being very prevalent, the behaviours of Western Australians aren't wonderful. In regards to tanning, fortunately, most West Australians don't like to get a suntan at about 70%, but nearly a third still like to get a suntan, as you can see there on that table. The bigger issue is with young people. So about 50% of young women like to get a tan. Most West Australians know the consequences of not using sun protection, and they know how to avoid skin cancer. However, they're still displaying those behaviours. So basically, that desire to tan and actually being tanned is more common than we would like. Overall, those sun protection behaviours have improved a lot since that initial image I showed you at Cottesloe Beach, but these behaviours have plateaued in recent years. So similarly, West Australians could improve sun protection behaviours. Largely, we spend long periods outside with inadequate sun protection. Here you can see the mean time outdoors in peak UV periods is 110 minutes, and that's taken during summer. But only 22% of the population is wearing a brimmed hat, and it's actually only 3% of 18 to 24-year-olds. 43% are using sunscreen and 18% are wearing long sleeves. So these are the basics of our slip, slop, slap message. 15% of the population and about a quarter of young people report being sunburnt on the weekends. Now, the figures I've shown you here, it's actually quite a small study, but these figures are similar to other data collected by the Cancer Council. So we know that the major cause of melanoma and non-melanoma skin cancer is UV exposure, and UV is a class 1 carcinogen. But that pattern of exposure also seems to play a role, as Gary mentioned. So childhood and adolescent sun exposure is thought to be important in determining the lifetime potential for skin cancer, while adult exposure appears to contribute to the extent to which this potential is realised. While the exact level of exposure needed to develop various skin cancers is not entirely clear, it's likely that both the intermittent and cumulative sun exposures are important. Non-melanoma skin cancers are more frequent on parts of the body that are commonly exposed to the sun, such as the ears, face, neck, and forearms. This implies long-term repeated UV radiation exposure is a major causal factor. Now, Gary mentioned the Fitzpatrick skin prototype. So those with skin type 1 and 2 are at the greatest risk of developing skin cancer. It's that white skin that is very sensitive to the sun and burns easily. Skin type 6, or those deeply pigmented skin types, they do offer more protection against UV radiation than other skin types. But the skin cancers can still occur in people with this skin type. Our sun protection messages are the same regardless of skin type. Although those skin cancers in darker skins are less common, it's often found at a more advanced stage. So while the risk is still there, the risk is smaller, so it is the same message. Other risk factors, again mentioned by Gary, family history of melanoma, a childhood in Australia, working or spending a lot of leisure in the sun, deliberately exposing their skin to the sun, and blistering and severe sunburns in childhood. So our prevention messages are hopefully fairly simple, knowing that too much UV is the overwhelming cause of skin cancer, knowing when the UV is high enough to do damage, and stopping that UV from reaching the skin. The message is simple: when the UV index is 3 or above, be sun smart. The old message of slip, slop, slat, seek and slide has been around for a long time. And although that's familiar, sometimes there is a bit of confusion around those behaviours. So the UV index is an international standard. It was developed by the World Health Organization, and it refers to UV levels at the Earth's surface. We talk a lot about UV in SunSmart, and that's because there is generally a pretty poor understanding of this index. This index is weighted to account for UVA and UVB, and daily forecasts account for ozone and climatic variations. Despite the graphic that's shown here, it actually starts at 0 and it has no upper limit. The UV in Perth in summer regularly reaches 14 and 15. As the number rises, the UV becomes more intense and skin damage occurs faster. The main number to remember, and the main number that we promote, is UV3. So when the UV index is 3 or above, that's when sun protection becomes necessary. So this is a graph of a very typical summer's day in Perth. The UV forecast is always a bell curve. It always peaks around about solar noon. This is on a clear sky day. And there are times at the beginning and the end of the day where the UV is below 3. That curve flattens in winter, and it also flattens the further you are from the equator. So you'd expect levels in Perth to be lower, and you would expect levels throughout the year in places like Broome to be quite high. Just as a side note, last year in Perth, there were only 15 days when the UV did not exceed 3. So it's sometimes a misconception that sun protection isn't needed in winter, but that's not the case. Our recommendation is to check the UV in your local area and every day if you can. Watch out for seasonal variations that cause that height of that graph to change. Don't assume that sun protection is only needed in summer. Check the UV. As a bit of an example, I just had a look at the SunSmart app. The UV in Perth today is expected to reach 6, but it's only 22 degrees. So if Gary's going out to play golf today, then I'd recommend check the UV first. And if the UV is going to be above 3 when he's playing, use sun protection. So that UV index is very readily available. That bell curve that I just showed you is from a Cancer Council website called MyUV, which is also shown on that top left-hand corner. That will show those UV graphs for locations across Australia, and also a few real-time UV readings as well. Bureau of Meteorology also has that information. So there's a clip there from their website and also their free weather app that is used quite a lot. They will show the sun protection times, which is basically the times when the UV is above 3, and it will show the maximum UV. The other one I'd recommend is the SunSmart app. So it's a free download. In Perth, it will also show you the real-time UV. So out of interest at the moment, the UV is 2.5 here in Perth. I would assume because the sun protection times at the moment are 9.3. I can't tell because I'm indoors, but maybe there's a little bit of cloud cover that's reducing that UV a little bit. But today that will increase, peak at around solar noon, and then drop again to be below 3 at 3 p.m. this afternoon. So one of the main misconceptions that the public have is that sun protection is needed on hot days. This is a little clip from the Bureau of Meteorology website, a very typical Perth forecast. You can see that there's a variation of 11 degrees between Wednesday and Thursday, but the UV is actually higher on that cooler day. So if you were going to plan, again, I'll use Gary as an example, to go out and play golf that week, he would probably pick that 27-degree day, but the UV is actually going to be higher. Most people assume that the UV is that sun damage only occurs on hot days, and that's when you need sun protection. UV is not the same as heat, and it can't be felt. It's at opposite ends of the light spectrum. Most people actually get sunburnt when their temperature is between 18 and 27 degrees. You might hear people say, I can feel my skin getting burnt. They can't. What they can feel is the heat from that, the radiation, not UV. So it's a very different thing. So our message, be sun smart when UV is 3 or above. It's one we say over and over again. These messages are not new, but I'll explain some of the common myths around these messages. So it is a little bit different for infants under 12 months. They shouldn't be purposely exposed to direct sunlight when the UV index is 3 or above. And that's because of the sensitivity of baby skin. So we recommend to plan outdoor activities before, out of those times when the UV is above 3, and to cover as much skin as possible. So that's clothing, hats, and if possible, sunglasses and shade as well. Sunscreen is not recommended to be used widespread on babies under 6 months of age. So, and babies 6 months to 12 months, only small areas of the skin that can't be covered by clothing or other means. We'd recommend a small patch test of sunscreen first, and to use either sensitive or kids formula sunscreen. Also, just to learn sun protection behaviours early. So role modelling from parents is absolutely crucial for children to continue those sun protection behaviours. So slipping on sun protective clothing. Clothing is by far the most effective sun protection measure. It provides a physical barrier between the UV and the skin. It's the most effective way. As you can see there in that photograph, you can see where the t-shirt starts and where it finishes. Most clothing does provide some protection against UV, but I guess the closer the weave and the denser the fabric, the better it will be. Garment design is also very important, so clothing should aim to cover as much skin as possible. So sunscreen. A lot of people think that sunscreen is a bit of a shield of armour. However, it's absolutely not the case. No sunscreen ever blocks all UV radiation, and you should not rely on sunscreen alone. If you go to the beach in a bikini with just sunscreen in the middle of summer, you most likely will get burnt. Cancer Council recommends that sunscreens are just used to protect the areas of the body where physical protection is not adequate. It's best applied to clean, dry skin, and sunscreens never block out all of the UV, so you're not completely protected by sunscreen. Most Australians don't use enough sunscreen, and that means that sunscreen users achieve a SPF or sun protective factor of between 50 and 80% less than specified on the label because they're not applying it properly. The proper application is 1 teaspoon per limb or 7 teaspoons per full body application. In terms of a standard tube of sunscreen, which is 110 mils, that's a third of one of those tubes that then needs to be reapplied every 2 hours. So you need a lot of sunscreen for it to be effective, which is why clothing is cheaper, easier, and more effective as well. So there is a new recommendation around sunscreen use, and that is that for people living in Australia and New Zealand, to apply sunscreen every day when the UV index is predicted to reach 3 or above, regardless of your planned sun exposure. So that means making sunscreen part of that morning routine, getting ready in the morning. The increased use of sunscreen as part of that daily routine has been shown to reduce that incidental sun exposure, which leads to a decreased incidence of skin cancer in the future. So that means for someone like me who's mostly office-based, I would put sunscreen on. I do put sunscreen on every morning, and it just covers those periods such as popping out to get a coffee or hanging up washing or that kind of thing. You know that there's sun protection there, and it has been shown to reduce the incidence of skin cancer. So is sunscreen safe? The quick answer is yes. It is regulated by the TGA to ensure it is effective and safe to use. All sunscreens that are sold in Australia will have an SPF factor, and if it's called sunscreen, it means it has been regulated by the TGA. The nanoparticles that are used in sunscreen They can be used to reduce the white residue that is left on the skin, but the TGA has conducted a review of that literature in relation to that nanoparticle use, which concluded that based on the best evidence, nanoparticles and sunscreens do not pose any risk to health because those nanoparticles stay on the outer surface of the skin and don't compromise those non-viable cells. So slap on a hat. So not just any hat though. So you're looking for a hat that protects the face and neck area adequately. Again, as mentioned by Gary, a lot of those skin cancers and particularly SCCs and BCCs occur around that head and neck area. So using a brimmed hat is really important. Baseball caps and visors do not provide adequate protection for the neck and ears. So caps also provide a little bit of a false sense of security. People think they've got a cap on, it will protect them when it doesn't, as shown in that photograph there. You can see the gentleman with the red sunburnt skin who's wearing a cap. So shade is a fairly straightforward one. So that's just making use of trees, buildings and temporary shade or covering to provide protection from UV radiation. We always say to use shade and all of our 5 measures in combination because of the reflective nature of UV. Even being under shade, you will still get some reflected UV. Just a note with pram covering, so it's just aware that some of those coverings do increase the heat inside those prams, so just making parents of newborns aware that enclosing babies in those prams can just increase the heat significantly. So sunglasses are also our last recommendation. Another thing to note with sunglasses, a broad brimmed hat also reduces UV to the eye by about 50%. Again, because of that reflective nature of UV, we recommend a close fitting glass that's sort of a wraparound style. So our population early detection messages are, again, as Gary said, just that opportunistic self-examination. So the majority of melanomas are detected by patients themselves or their partners, but the melanomas that are detected by doctors do tend to be thinner. Cancer Council Australia encourages people to become familiar with their skin, including that skin not exposed to the sun, and consult a doctor if they notice any changes. We don't recommend the use of smartphone applications by consumers to self-diagnose skin cancer, including melanoma. There is an increase in technology in that area, but it's not quite sufficient just yet. Population-based screening is not recommended for melanoma or other skin cancers due to that insufficient evidence that it reduces mortality. So there are some, we do have on the MyUV website a bit of a guide for people as well to know what to look for, but our main message is check your skin. If you notice any changes, see your doctor. So just touching briefly on vitamin D. So this graph shows the dilemma. Too little UV leads to low vitamin D and the risk of skeletal disease. Too much leads to skin cancer and eye damage. So how much is enough? This is the big question. There is a statement online from Cancer Council Australia that lays out some guidelines based on season and location, but very broadly, those recommendations are basically what I mentioned. When the UV index is 3 or above, use sun protection. So given the evidence that shows UV to be carcinogenic, skin cancer prevention in Australia needs to remain very high public priority. For this reason, extended and deliberate sun exposure without any form of sun protection when the UV index is 3 or above is not recommended, even for those diagnosed with vitamin D deficiency. There are studies to show that sunscreen use has minimal impact on vitamin D levels over time. This slip, slop, slap message is been shown not to impact on vitamin D levels as well. So for most people, they get enough vitamin D through that incidental exposure to the sun, particularly in summer. Just a few minutes outdoors will be sufficient. Our advice is for when the UV index is below 3, spend time outdoors, particularly when in the middle of the day in winter when it might not be above 3, with some skin uncovered, and physical activity will also help boost vitamin D levels. So there are some at-risk groups, but again, the message is the same. Those people who may be at risk of vitamin D deficiency should discuss those requirements with the medical practitioner to determine if dietary supplementation rather than sun exposure is appropriate. And some of those at-risk groups are listed there. So that just about concludes my talk. So again, it's the same message: be sun smart when the UV is 3 or above. Have a good understanding about UV and make sure when the UV is above 3 that you're using those 5 ways in combination to reduce the impact from skin cancer. So thank you for your time, and feel free to get in touch with us if you have any questions or to follow up.
We're now going to transition to the final speaker this morning, Dr. Derek Eng, who's joining us remotely. And Derek, yep, you can see Derek, and we'll unmute Derek in a little while. So Derek, can you just share the slides and while we set that up? So Derek is a palliative medicine physician. He's presently the head of department in palliative care at Royal Perth Hospital and St John of God Hospital in Midlands, Murdoch, and also Subiaco. Derek works as a senior clinical lecturer in palliative medicine at UWA and Notre Dame University in Fremantle. So this morning, Derek's going to be speaking about end-of-life conversations, a topic that can be challenging in general practice, advanced health directives, and a few other things. So I will hand over to Derek now.
Thanks, Eric. Welcome, everybody. Thank you to Eric and the organisers for inviting me. I'm only at Royal Perth and Subiaco, just for the record. That's probably enough. I won't be able to. Certainly there's another team at Murdoch and Midland. But today, I think I'd like to have as interactive a session as we can, but I'm not sure how easily that works from a Q&A point of view, but certainly use your chat. I think it will come up on my screen if I can. I'll just keep an eye on the chats anyway if someone's got a question as we go. So I was told to probably concentrate on talking about end of life rather than specific symptom management strategies and drugs. So I think we're just going to start with probably what is the most difficult part of palliative care, which is who should be seeing a palliative care specialist, but even more difficult and pertaining to general practice is what can you do as a general practitioner seeing a patient who possibly is deteriorating. So I'm just going to move through. I've got quite a few slides. I'm going to try and concentrate on goals of patient care or advanced care planning, which is probably the most important thing at the moment as far as, you know, people with chronic illnesses facing maybe an acute illness on top of that being COVID or influenza or whatever else there is. And that's a difficult conversation because advanced care planning is so complex, I think, for a lot of us, whether you're a general practitioner or nurse or anyone. The precedence for this sort of conversation has been not for resus. And not for resus conversations are just terrible conversations. They're nothing that we've actually trained for. And there's really good and increasing evidence that it scares patients. If you say, well, we're not going to restart your heart. If your heart stops, that's okay, isn't it? It certainly isn't okay. All right, I'm going to kickstart my PowerPoint now. So palliative care in 30 minutes is impossible, but what I'm trying to do is give you that whole sense of, you know, why, when, what, and how is one of these kind of lectures. So looking at leading causes of death, it may be obscured by your little presenter videos things, but top 5 leading causes of death in females and males, but the female ones are presented there given the topic of today. Just remembering that, you know, dementia and ischemic heart disease and cardiovascular disease, cerebrovascular disease are the top 3, which means that advanced care planning is really important. And as you probably know, most women being kind of matriarchal and householders are very much keen to make sure their families are looked after if anything was to happen to them. So advanced care planning is vital. What is palliative care? This definition you may not have seen. It's came about a couple of years ago. You would have seen the WHO definition, which is equally long and clumsy, but what we like about the International Association of Hospice Palliative Care's definition is this, that it's probably more reflective of what we do. So palliative care is active, holistic care of individuals across all ages with serious health-related suffering. And it's especially true near the end of life, but we know that from increasing evidence that palliative care, preparation of what there is to come is really, really important. And not just preparation, but then we can start to look at quality of life issues right now rather than wait until death is imminent. So if you look at, you know, what does it include? It includes certainly prevention and early identification, which is where I think general practice is really well placed for it. And it's what you do. So I'm not hopefully telling you how to suck eggs, but, you know, as a general practitioner and having done general practitioner before, for me, it's very much that early phase of looking after the person and the whole person. I like this definition because this is what we do. You know, a lot of people say, oh, palliative care is so depressing. Well, it isn't, because what we're concentrating on is living as long as possible until death, or until, you know, the compromises become overwhelming. And so much of it is about effective communication, helping people to understand and prioritize goals. You can read the rest of here, but I just highlighted the neither postponing death or hastening it, because we're trying desperately to distance ourselves from the coming euthanasia legislation that is, people are thinking, well, that's a palliative care problem. It isn't. Okay, so this is part of the problem with goals of patient care or advanced care planning. Without advanced care planning, this is what the patient thinks, and this is what most normal people think, that this is modern healthcare. Live life, live the dream, get sick, get injured, go to hospital, get fixed up, go home. But unfortunately, that doesn't happen when you get a chronic illness and when you get sick. You leave this cycle and you enter this side pathway, which means incomplete recovery and then eventually death. And this is the whole problem, that if we don't say to a patient that you're no longer in this cycle, you're actually in this sidearm, most people will just think and expect this to happen. So conceptually, I think this is really important. Now, going into, you know, who might we need to talk about end of life with, the surprise question is a really useful one, and most people would have heard of this by now. So if you're not surprised that someone's going to die in the next 6 to 12 months, then you really need to be starting a conversation. And then I'm going to go into how to have this conversation in a minute. So the gold standards framework, this is the prognostication identification guide. So that's a really useful guide. So this little QR code, if you know how to use it, then use it now. Basically, you just point your camera on your iPhone or smartphone at it, and it will pop up a little link. If you go to that link, it takes you to the most recent example of the gold standards framework, PIG. It's a really useful tool because beyond the surprise question, you'll then see some general guidelines to how to identify a person as nearing the end of their life. And then there are some specific tools to help you if they've got cerebrovascular disease, cardiovascular disease, cancer, whatever it is. But I like the gold standards framework. Some of you might know the SPIC tool. The SPIC tool is less, I don't like the SPIC tool as much as the gold standards framework because the SPIC tool has now gotten rid of the surprise question, which is just such a no-brainer. It's so easy to use the surprise question. So certainly if you've got your smartphones and get into that and have a look at that. Right, so then once you identify someone as maybe having the last 12 months of their life, it's well and truly a good time to start talking about some advanced care planning. And remembering again that until now, advanced care planning was a very stupid question that said, and I'm not blaming anyone because no one taught us how to do this, and I did it as well. This stupid question of, what do you want us to do if your heart stops? And then the corollary of that is, well, we're not going to resuscitate you if your heart stops. You know that, don't you? I mean, that's just such dumb questioning, and the evidence is increasingly showing that that's not useful. But we've all done it, unfortunately. So what I want to do today is show you a different way of having this conversation, that the evidence is increasingly showing that doctors should and can do this, and doctors are getting just better results, particularly in hospitals. So goals of care is really advanced care planning. In a hospital environment, it very much identifies high-risk patients who might deteriorate suddenly and might enter the end of life. But you can use the same principles earlier on. And remembering that highly interventional healthcare, doctors know this, that highly interventional healthcare not only doesn't benefit, but it causes harm. And this is the thing that's really key. It causes harm. And hospitals are also interested because it is patient-centered care, but it also saves money. And I don't want the cynics in all of us to start thinking it's because it saves money. But at the end of the day, it's really about patient-centered care and not doing harm. What and how to have this discussion? Well, so in all my teachings about communication skills, both at Cancer Council, because I'm one of the communication teachers for PACE, the Palliative and Supportive Care arm of Cancer Council, and we run lots of workshops. Some of you may know this, but I'm also running workshops at a hospital level. When we have conversations about goals of patient care or advanced care planning, there are really three types of conversations. There's the hypothetical conversation earlier in the piece. So when someone's quite well, you can say, have you thought about your life and how you might want to live your life if you became unwell with, say, a stroke or a heart attack, or if you weren't living your life the way you currently do, what kind of decisions would you make in that context? When someone's really well, it's a very hypothetical discussion. And that's a kind of easier discussion because there's no emotion attached to that. And they're usually not sick, and therefore they're not cognitively impaired. If they're not, sick people are cognitively impaired. There's good evidence to show that. Then there's the conversation that a lot of intensive care, some of my colleagues in ICU and hospital settings, they think they can do really good goals of care conversations, but really it's a breaking bad news conversation. So at the end of the day, when nothing else can be done, it's breaking bad news. You're really just saying your body's falling apart, your heart's not going to survive this, or your lungs are not going to survive this. Full stop. The trickier conversation is this one in the middle, which is a shared decision making. This is where there are multiple potential options. Some are more aggressive than others. How do we have this conversation? This is what I'm going to hopefully share with you in terms of what we're teaching in that space. Okay, what it involves, this kind of new shared decision paradigm, and why it's so different, and why I think is the key to its success, is this. We're having this kind of values-based conversation using these questions that I've formulated using some of the evidence coming out of Boston. So everyone probably knows Atul Gawande. So his groups really started to work on this, and I'll show you the reference in a minute. So when you're talking about patient values and goals, what is it about your healthcare that's important to you now and then into the future? What physical functions can't you live with? And what physical functions can't you live without? That's a really important question. And again, it's a paradigm shift. We don't ask these questions normally. This is whole new world stuff. But what's important to you is something I now routinely ask. And people will go towards healthcare because as a doctor or a nurse asking this question, they're not going to tell you about, winning lotto. I mean, they might, but at the end of the day, it's about healthcare. Then the last few questions here are really useful in unpacking this kind of worst case scenario. So what can't you live without? What medical treatments would you endure to live longer? This is for patients who say, well, doctor, I want to live longer. What do I have to do? I'll do anything to live. Well, doing anything to live, what does that actually mean? You're going to live a compromised existence. Are you willing to live with that? Okay, so what does that look like? You want them to be able to put words around this future that would be unacceptable. So for example, I would want the patient to start articulating, well, I wouldn't want to be in a nursing home, but why? Oh, I wouldn't want someone looking after my everything, wiping my bottom. I wouldn't want to be stuck in bed. I wouldn't want to be able to not see my family or not speak to them. And in this COVID era, I wouldn't want to be stuck in a nursing home where I'm isolated from the rest of my family. This is ridiculous at the end of life, but it is what we find ourselves stuck with. And then help me to understand why that's important. So often it's not good enough for someone to say, well, I don't want to go to a nursing home. But what is it about that? Is it about not being at home, not being independent, not doing the things I want to do, not having control? What is it? Okay, so that's what we'll come back to. But I'll show you the framework now that I've been teaching in an example. So I might have to just gloss through this and then take questions. So for example, if we're talking about a lady who's 66 odd years old, for example, who used to be a teacher, ex-smoker, COPD, which is common in the community, they might see you either with an acute exacerbation or they might just see you as a checkup. I think it's important then, you might want to seize the opportunity if you think they're in the last 12 months of their life. Exceedingly difficult to predict. If they've been going to hospital a lot, if their lung function seem to be deteriorating because they're more breathless, doing less and less, then you might need to engage in this discussion. Okay, so how do I go into an end of life kind of advanced care planning discussion? I use the ICE question, so all the medical students now know this because they're being taught it. We might have skipped this depending on when you did med school. What do you think's going on? So most of us would do ideas. What do you think's going on? What did the specialist tell you? What did they tell you in hospital? So I just ask patients, what do you think's going on? And they might say, well, it's probably just another chest cold. So just going back to this example of a 66-year-old with chronic lung disease and an infective exacerbation. So I spend a lot of time in the ideas, what do you think's going on? Why do you think that? What do the doctors want to do? Then there's the concerns. So what worries you most? Fiona Lake, very respected respiratory physician at Charlie's, uses this question: what scares you about this? And most people talk about death when you say what scares you about this. So it's a really lovely entry into what is it that scares you about having this condition and the future. What worries you tends to give you more sort of cognitive things. But I would always say, what worries you most? So this person might say, oh, I hope it's not COVID, or I hope it's not cancer, or I hope it's not whatever, you know. Expectations is something that as doctors, we probably haven't learned to use. It's so important. So if you've got a patient in front of you, it's really helpful to diagnose their insight levels. So where do they think this illness is taking them? Do they really understand this illness that they've got? So what do you think we should do? What do you think will happen? You know, what will happen to you? What will antibiotics do for you? And then I've recently been using this question, do you have a plan B? So if they're really optimistic, so if they say, oh, doc, you know, everything will be fine. Don't worry about it, doc, you worry too much. I normally say, well, you know, I am a bit worried. Do you have a plan B? So what if things don't go well? And it really tells you where the patient's at. Do they really understand the illness? Do they really understand where they're going with this? So the ICE questions, remember, really much more used for me now than anything else, but I'm a palliative care doctor. I've been teaching this to acute, to registrars working in ED, registrars working everywhere, and they find it really easy. The expectation questions. Also, what I've been using with expectation is, what do you think is going to happen to you in the next few weeks? Or what do you think is going to happen to you in the next few months? Just getting insight, you know, do they really understand or not? So that should quite easily lead you into a goals of patient care or advanced care planning conversation, because this question ultimately leads to function. So, you know, I think, doctor, I might not be getting better, or I might be getting worse. All right, well, what does that mean to you in terms of your health and what's important? So REMAP is from Vital Talk. Again, Vital Talk's an American organization that have been teaching doctors to communicate for about 15 to 20 years. This is their framework. I use it, it's very good. There's a website, just in case, it's called Vital Tips. So Vital Tips has the REMAP framework in it. It doesn't have ICE. This is me putting ICE and REMAP together. So the nice thing about ICE and REMAP is it's part of a normal history, which then leads to a goals of patient care discussion. All right, I'm going to show you REMAP as quickly as I can. I don't know how much time, probably I've got 5 minutes, but I'll show you what it is, and then we can ask questions, and you'll probably have a copy of the notes. So let's start off with ICE. So what do you think's going on? Where do you think this is going for you? And this lady says, oh, get me onto those antibiotics and get me better, doc, so I can get back to work. I don't need a plan B. So I'm purposely showing you how difficult this conversation might be. Most patients will actually smoothly go into it, but, oh well, 50% of patients won't. Then the important thing about reframing is you're actually trying to move the patient towards something that they may not have thought about. So acknowledge what they're saying. Okay, I hear that you're pretty confident this is going to work, and I really hope it does. So my 3-step method in reframing is that I hear, I hope, I'm worried. So I hear this, I hope it will happen, but I'm actually worried it's not going to work. Maybe your lungs are getting worse. So this is the reframe. You're starting to throw a spanner in the works very gently. The beauty of this working now, whereas previously your efforts might have failed, is if you say, look, you know, I think your lungs are getting worse and you might die. It's just too much of a clangor for the human psyche to deal with. So if you're actually buying into it, for doctors who don't have a lot of rapport with their patients, because you might be seeing them as a substitute GP or whatever, but it's a really nice way of establishing some sort of rapport. I hear you and I hope it works, but I'm actually worried it doesn't. So if it is a clangor for them, use the nurse's mnemonic for the emotion. So E in REMAP is expect emotion. And the nurse's mnemonic is this. So they're going to be emotional. So it sounds like you're really upset. Sounds like I've confused you. Sounds like you're really shocked. You can use some of these other tools, understand the core message. So I understand that you are really optimistic, but I am really worried. You know, I understand that you're a bit confused and you're wondering why we're even having this conversation. Respect and reassurance at the right time. You know, it's really useful for family members who get really anxious about their family being sick. So, you know, I know you're really worried about mum. I know you really care a lot about mum, but I really think it's time for us to talk about this. Support, bunch of different skills. It includes touch and tissues. But I actually like using it in the, you know, I just want to make sure we're doing the right thing by you, hinting that aggressive medical care is not always the right care. Tell me what you're feeling right now. So people who go quiet, people who are really shocked, silence is a massive time killer. You will need a bit of silence, but to try and re-engage them again, get them talking, explore what's going on. So tell me what you're feeling. Tell me what you're thinking. You're really quiet there. Talk to me. Okay, really useful tool to pull people out of the depth of whatever the emotion is. Okay, so I might just move on from here. So if you've done the emotion thing, move into the mapping exercise. So if they're starting to talk and starting to think, here's another QR code. So this is what I was telling you about. So from Boston, the serious illness conversation guide, this is what I alluded to earlier. What's most important to you now? What would you think is important to your life in the future? So this patient might say, well, I just want to get better and get on with my life. Okay, well, help me to understand what being alive means to you. So I use this language. What does being alive mean? What does living mean? Oh, I just want to be able to be with my family, to work, to save some money, retire, whatever it is. Okay, well, then, so what functions are important to you? What can't you live without? Sometimes I have to give examples because people would never have thought about this. So some people I speak to, they think that talking and being with their family is really important. They think that having a clear mind, being independent, living in their own home, what functions are really important to you? And then if they say, yeah, you know, all of those things, then what things can't you live without? What would be unacceptable? What if things get worse? So this is getting into the territory where we're saying, we really want to look after you in a way that's important to you. And we really don't want to be doing things to you that keep you alive, but erode your quality of life. So what would be unacceptable? And, you know, patients might, so they might still not understand. So I might say, well, you know, a lot of people find that communicating with your family, so being able to talk, being able to think clearly, being able to form sentences, being able to walk around, that's really important. Okay, so if you take nothing away from today, this is probably what I want you to start to do. There's not something you can easily do. I'm trying to get some grant funding to teach this to any doctor who cares, any nurse who wants to do this, any allied health professional. To teach a communication skill as difficult as this, you need to do simulation. So I need to put you through a simulator, which means you need to talk to an actor using these questions, fumble through it, because that's normal, but then find language that works for you. So to learn these skills, you might have to simulate it. So I get some patients who say, I don't want to be a vegetable. I don't want to be a burden. Some people say, I don't want my ass wiped, doctor. It's usually man to man, that kind of language, I've noticed. Ladies are a lot more ladylike, but I don't want to be, I don't want to be a vegetable. So I've got a question. Do you discuss pain at this early stage? I might just take more questions in a minute, but it depends on what you mean by that. As in, would you tolerate unacceptable pain? Look, I don't know. People, I'm very much patient directed here. If people bring up pain and suffering at the end of life, then I would absolutely say, well, yeah, let's talk about that. You know, this is a palliative care thing that I do now. I remind people that 90% of people will die peacefully. The problem with all this euthanasia talk that's just splashed all over the media is the fear campaign has worked. The fear campaign was by the advocates who said everyone's going to die suffering and badly. That's so not true. And I think patients need to know what the truth is and what the smear campaign is. We need to just tell patients, you know, with good palliative care, with early planning, you don't have to die this, you know, unbearably horrible death that you hear on the media. And yeah, there's a small percentage of people who are going to be symptomatic. They need to really fight for their rights to see palliative care, to be really, really honest with you. Okay, we're up to A and P. So A is the alignment with realistic goals. So there are some active goals here, treatment goals like, yeah, absolutely, we're going to help you with breathing problems. We're going to help you with back pain problems. In this case of this 66-year-old woman with chronic lung disease, yes, we're absolutely going to be able to work on the breathing. Let's try some antibiotics. Let's try some steroids. If you get sicker, we might put you in hospital with some intravenous. Yes, we'll do those things. But let's talk about the plan B. What about if that doesn't work? Well, if that doesn't work and we can't fix your lungs, what are we going to do? I wish statements are quite nice. It goes with the I hope. So if you're saying, I hope we can do this, if you think we cannot do this, like it's impossible, you can say, I wish. It's a really humanistic thing. You know, I wish we could do this, but I'm really worried that we're at the point when things aren't going to get any better. So these are sort of palliative goals. So you can align with some of the, yeah, let's do this and get you better. But we also need to align with the comfort that they're fearful of dying badly. They're fearful of being a burden. Let's align with that. How can we help? Also worth, there's lots of questions here. I might have to get to that in a second. I'll get to that in a second, sorry. So when we go to alignment, you might need to align with some stuff that you don't really want to do. So people who want resuscitation, we might have to say, well, or a ventilator, you might have to say, well, I wish a ventilator could help. I wish resuscitation could help. I wish CPR could help. But remembering that if you know what their goals are, you can say, you know, if you had to be resuscitated or if you needed to be on a ventilator, the chances of going home again are almost impossible. You know, your lungs just wouldn't cope on a ventilator. You would never get off a ventilator, which means you would die in ICU sedated. You know, that's the reality. Now, the problem with all of this is you may not be the person to make this call. But if you feel very confident that this person's going to die with cracked ribs with CPR, then you need to represent that as a person who's going to advocate for what's best treatment for them. So I might have to move on and take questions. The last part of REMAP is planning. So it's to summarize. So first thing is we need to control this breathless with some antibiotics and maybe some other medications the respiratory doctors might introduce. Document your wishes on an advanced care directive. That's really important. Talk to your family about your wishes. Most people are so afraid to talk to their family because they think it's going to scare them. But if you just talk to them about what's meaningful and what sort of existence you wouldn't want to put up with, that's really important. Just tell them what you really want of your life. So yesterday I was in the trauma unit, horrible traumatic brain injury. But luckily a few weeks before that, the patient said to the family, I don't want to live in a nursing home. I don't want to be a vegetable. I don't want to not be able to speak to you. Well, that's exactly the situation he's in now. And the family have said, look, he's told me that. We're not going to do that to him. Makes life so much easier for everybody. The poor guy was, you know, restrained in bed, tied down, couldn't speak because he had a left hemisphere full of blood. You know, we needed to sedate him and unstrap him. It was a horrible end of life. Okay, so practice tip, if there's an impasse, look, don't fight what's unfightable. Just say, okay, right, for now, you want to be resuscitated, you want everything, fair enough. you know, when the time comes, you might feel differently, but I think very much think about what's important to you. In hospital, we use time-limited trials. Okay, for now, let's put up some fluids. Let's put up some antibiotics. You should be feeling a whole lot better after that. If you're not, then we're not going in the direction you want to go to, which is going home. Nobody wants to live on a ventilator. God help us. I don't know who does. And some people in America clearly do. But at the moment, you're going to get a lot of traction out of a conversation like this. Okay, take-home points, clear identification of values and goals, document some of these, ICE questions and remap will get you there. If the family and patient pull you back towards procedures, you know, what are you going to do? You're going to resuscitate, you're going to go on ventilator. Go back to values and goals. Why are we doing this? What's important to you? Independence. What's important to you? Speaking, having a clear mind, returning home. Well, we're never going to return you home if we get you on these things. Okay, don't worry about that. Questions?
So we'll run the questions as a panel to all the attendees. So there's Derek remotely, and then if you can turn on your video, we've got Gary and Sally here as well. So we'll just get set up for the questions. Excellent. So we've got a number of questions that we're going to go through, and I'll read out the questions and then we'll go to the presenters. While we've been running this, Derek, I think we'll go to you first because it's quite topical. So the first question was from Jennifer. Do you discuss pain at this stage?
Yeah, so I thought I touched on that, but maybe some clarification of what that, sort of at what stage. Do you mean when someone is really well and pain is a hypothetical thing?
So Jennifer, are you still there? Did you want to add more information? While we're waiting for that, we'll go to the next question, Derek, which is, would you encourage us as GPs to involve palliative care for patients who have a terminal cancer diagnosis, but are still receiving active treatment, for example, chemotherapy? I find that oncology specialists looking after these patients often don't involve palliative care till quite late.
Correct. So this is where palliative care, so the answer to that question is simply yes. So I'm now seeing lots of chronic lung disease patients who are not dying, and I might have them for a few months, but I think this is going to overwhelm palliative care services if everyone refers people early. And that's where I think GPs are well positioned to have conversations about advanced care planning. But if they have symptoms that are really difficult early on, absolutely, the oncologists aren't specialists at managing symptoms. They're still thinking, let's just get this thing treated, and then we can look at, and then hopefully the pain will get better or whatever. If you think there's a symptom that needs treating, that includes complex social, complex psychological things associated with cancer, then refer them.
Thank you. And I guess with Jennifer's question, it might be in that curve where pain at the early stages before things start to deteriorate. So I guess that's what she's getting at. Yeah,
so yeah, absolutely refer early, but I think, and at the least you can get in touch with us for some advice. So to be really honest, palliative care is so thin on the ground. So I don't know if you guys know the stats. Yeah, so I can see that, Jennifer, you said pain often scares patients. And that's what I mean about the scare campaign that ran so successfully with VAD last year. Everybody thinks they're going to die horribly. In fact, that was what was said in Parliament. You know, shame on you for voting no because you're going to commit someone to a horrible death. That campaign was really effective. So patients are going to come to you really scared. So I would say, look, you know, majority of patients die really peacefully. Most people, I'm actually telling a lot of people that the body's going to shut down a bit like a computer does. It shuts down nice and slowly. It doesn't tend to crash. So I think it's important that patients know that. and that you're committed to looking after them, and that there is such a thing as palliative care that looks after the symptoms.
Thanks, Derek. Keep those questions coming through. It's a really interesting morning of educational talks. I'll hand over now to Gary and Sally for their questions, and we'll come back to Derek if there are more. So the first question was for Gary. Do skin types 4 and 5 need sunscreen in summer?
I might actually let Sally answer this one.
Yes. So there was a little bit of a change in the recommendation a few years ago, and now all skin types we do recommend use sunscreen, but not only in summer. So whenever the UV index is above 3, all skin types should be using sunscreen and other sun protection measures.
Okay. So the next question for Sally and Gary is there evidence to suggest arc welding is a risk factor for skin cancer?
Yes, there is. Arc welding produces a broad range of UV types. From sun exposure on the face of the Earth, we only really receive UVA and UVB. UVB is more intense but more superficial. UVA is a gentler but more penetrating type of UV and is more prevalent at the Earth's surface. But with arc welding, you get also UVC, which is highly toxic. And if workers are not protecting themselves adequately, they'll get quite an acute sunburn, blistering. And so they have quite thorough standards for personal protection. There was a good case control study showing that skin cancers are slightly increased, but really only significantly for BCC in the exposed areas over and above matched controls. There was no evidence that melanoma is increased on the skin. However, there's good, strong evidence that ocular melanoma is increased with arc welding. And it depends on a few factors, but what sort of welding? I think gas welding is the worst. Plasma welding or plasma cutting is not as bad. But by far the most significant occupational UV exposure is when workers work outdoors rather than with arc welding. The increased risk with BCCs is only around 2 to 3 times, with quite a broad sort of range of results. So, but it looks like it's slightly significantly increased.
Thanks, Gary. The next question for Gary and Sally is, I think this one's for Sally. The SunSmart app says it's from Victoria. Is that the right one?
Yes, that's it. It is. So it's developed by Cancer Council Victoria, but it gives the UV reading nationally and lots of different sites. It's linked to Bureau of Meteorology data. So yes, that's the one.
Thank you. Any more questions from the audience?
I think there was one more, sorry, for
radiation. Or...
Where's that one?
I think Alison asked about
oh, yeah.
Other non-radiation burns, I think it was regarding.
Yes, that's right. So there's a question about, does having had non-radiation related burn predispose to skin cancer in the site?
The answer is yes, it does. Squamous cancers are far more common in scars from any cause really, but particularly from burns. And this is true also of some inflammatory disorders. So rather than traumatic burn, there are some dermatoses that can increase the risk of cancer, particularly lichen sclerosis. Genital lichen sclerosis can increase the risk of SCC, as can HPV infections, and lichen planus and some other conditions. So the answer to the question is yes.
Thank you. Sally, did you have any other information you'd like to add for the audience before we throw back to the questions?
No, I think that's Gary summed that up nicely.
Okay, and where else can people find out more information from you?
So we do have a guide, so clinical guidelines basically. So contacting Cancer Council, having a look at Cancer Council's website, but also encouraging if you do have patients that they're very welcome to get in touch with us, and they certainly do. So particularly questions around UV and sunscreen safety and things like that, we're happy to answer for anybody, including the general population.
Thank you. And Gary, any other tips for the audience?
I'd encourage people to not be fearful of their dermatoscope and to make use of it. The majority of concerns arise for that intermediate lesion where you're not sure, and there's help available via dermatologists, plastic surgeons. If something might need a biopsy but it's too big to excise, you can always refer on. You can consider your pathologist a useful resource as well. So there's help available if you're not certain about a particular lesion.
Thanks. And Derek, I know you've had to compress quite a lot of information in 30 minutes on a very broad topic. For the audience, you mentioned that there are workshops. Is there a communications workshop that GPs and practice nurses could attend and through the Cancer Council?
Yeah, so if you look at the Cancer Council communique on workshops and education within PACE, the Palliative and Supportive Care Education arm, there's a communication workshop that usually runs once a month, once a fortnight, depending on whether we fill it up. It's mainly doing emotional cues stuff. So if you're getting very emotional patients, that's probably the first module to start with. And then from there, we're hoping to build on more modules, including the advanced care planning and goals of care stuff. At the moment, the goals of care module is quite a complex module, so we're just building that. The ones I've run at Royal Perth have been really successful, so I'm hoping to roll that out broader. But certainly do the emotional cues workshop through Cancer Council, and then if there's an appetite for things like breaking bad news and discussing end-of-life care and all of those topics, certainly register your interest. But the starting point is to do the emotional cues workshop.
Thanks, Derek. And for the audience, the Emotional Cues workshop is advertised on the Cancer Council website. So it tells you all about the date and the times and the fees. I've been to that workshop that Derek's run. It's excellent, and I highly recommend it to GPs. It's a good spend of your whole day to learn about these skills and to improve on them. And those websites and QR codes and links that Derek mentioned are very useful. It's something that we all will encounter in our day-to-day practice, and we can always get better at it. Any other tips for the audience, Derek, or any other comments?
Yeah, so I just wanted to mention the QR code for that serious illness guide, the one from Boston, talking about the second QR code that I put on my lecture. You have to register to get the serious illness guide. So I think I did it. It's quite simple. You just have to say who you are. It's the usual kind of making sure you're a healthcare provider, not some blow-in. So that's quite a good one. So I mentioned Vital Tips. So that's Vital Talk. It's a free app on your phone. It's a really useful app as far as trying to remember or learn mnemonics. So if you're thinking, oh gosh, what was that Breaking Bad News mnemonic? They don't use spikes, they use something else, but that's fine. Vital Tips has all of that, including there's a whole lot of COVID-ready communication tips for people who, touch wood, us in WA, pretty safe at the moment. But, if someone says, oh my God, if I get COVID, I want a ventilator. And you think, oh geez, how do I respond to that? The Vital Tips has a response to that. So it's a really useful app. So Vital Tips, if you just search on the App Store.
Thank you. So I just remind everyone who's listening to the podcast, the webinar this morning is that the Cancer Council will have these on their website in a few weeks' time, so that you can look through the material at your own leisure. I would like to thank the presenters for this morning. I'd like to thank Gary, Sally, and Derek for their time. I'd like to thank the 30-odd people that have spent a few hours this morning to improve their knowledge on skin cancer and skin cancer prevention, and also communication in a palliative care setting. Thank you very much for attending. And I'd like to also end this meeting by acknowledging the traditional owners of the land we're meeting on, the Whadjuk Noongar people. So everyone, take care and have a lovely weekend. Thank you very much for your time.